Okay, and now we're getting to interstitial lung diseases. So interstitial lung diseases. And as I said, there are so many, like more than 100, maybe more than 200. And these diseases are heterogeneous, but in many aspects, they're very similar to each other, especially in, let's say, in clinical presentation. So remember, first of all, the main hallmark is that the patients feel dyspneic, and dyspnea is typically exertional. Okay, so exertional dyspnea, that's very typical. And this exertional dyspnea, they come really in late stages. Okay, so they're not able to walk at home. But originally, if they think it back, it starts like few years before that. They feel like dyspneic, but they can resist that till a certain point. So it's progressive and it worsens and worsens, and after it gets to a certain degree, they feel really bad. Then typical is a non-productive cough. Okay. So they're coughing, but it's not productive in comparison with the obstructive diseases. And then, of course, if the disease gets worse and worse, later in time, they can be cyanotic, cyanosis, or even in some cases, in severe cases, they have a clubbing of fingers. Okay, so that's in chronic hypoxemia and hypoxia. Okay, but the main hallmark is the exertional dyspnea. Okay, remember that. And then also, it's about chronic inflammation and then fibrosis. So it can be inflammation and fibrosis, or at the end, only fibrosis. It depends. But the thing which you see in most of the cases, the progression depends on time and it's heterogeneous. But anyways, the best, let's say, diagnostic evaluation to use is a CT. And what you see on a CT typically is a honeycomb pattern. So remember honeycomb pattern. That's very typical. Typically, you use a high resolution CT. And if you see this, you see patients with, let's say, dyspnea. This is very significant. And the other thing you're going to do, you can do PFTs. And what you will see on PFTs typically are the decreased volumes, of course. So vital capacity, total lung capacity is decreased. There are decreased residual volumes and decreased FEV1. Okay, remember. But let's say the ratio of FEV1 to forced vital capacity normally is going to be decreased, but the ratio of FEV1 to forced vital capacity can be normal or even increased. Okay, so remember that. So intrapulmonary and, let's say, intrapulmonary and interstitial lung diseases, a huge number of diseases, but this is very typical for most of them or for all of them. Okay, yeah, and if we get more specific into diseases, you can divide them. You can divide them in different ways. And remember, it could be either because they inhale something that irritates in the lung. That's like asbestosis or silicosis. Okay, so these are, or coal workers' pneumoconiosis. Okay, or then you have systemic diseases. Okay, so either it would be like with unknown origin, which is sarcoidosis, or then you have these typical systemic autoimmune diseases like SLE. Okay, or you can have amyloidosis. Okay, or you can have all kinds of vasculitis. If they're located in the lungs, then you're going to have problem. And in some cases, you're going to have bleedings, hemorrhages in the lungs. Okay. So like vaginal granulomatosis, for example, although nowadays you call it granulomatosis with polyangiitis. And if I'm mentioning Wegener's granulomatosis, well, I should also mention then Churg-Strauss syndrome, which is nowadays called eosinophilic granulomatosis with polyangiitis. Okay, so as you can see, there are many. Moreover, I could name Goodpasture's, for example. Don't forget Goodpasture's syndrome is not only about glomerulonephritis, but you got vasculitis that is located in the alveoli as well in many cases. That's why you can have bleeding again. Okay? Or even if we talk about SLE, sometimes there's vasculitis, which is serious, and you have a bleeding in lungs again. Okay? So these all, and there are many other which will cause hemorrhages into the alveoli. Okay? And what is interesting with the hemorrhages in the lungs within the alveoli, if the blood gets into the alveoli, watch out. This is special. And I already talked about that in previous video, but it's about DLCO, diffusion lung capacity for carbon monoxide. In this case, in this measurement, you use really small doses of CO. And the method is nothing else than you compare the concentration of CO in the inspired air with the expired air. And if there is a decrease, it means there is some diffusion going on. That's what we assume. But this measurement gets distorted when blood gets directly into the alveoli because erythrocytes get there. And that's why CO gets directly bound to erythrocytes, which are in the alveoli already, okay? So it seems like, if you count it with this method, that actually diffusion is increased because the erythrocytes will take more CO from the air that you inhaled. But in reality, of course, the diffusion for gases will be decreased. Like the diffusion through the alveolar capillary membrane is going to be decreased because there's a liquid, there's blood in this case. Okay? So this is what I want you to remember. In case there's blood in the alveoli, remember and expect that although in reality the diffusion is going to be worse, it's going to be decreased for O2, CO2, and other gases, the DLCO will be artificially increased, okay? And you expect that. Okay, and then another thing I want you to remember is every time you hear about vasculitis in lungs, the thing you should remember is there's a high possibility that there is blood in the alveoli. There's hemorrhage, okay? So that was about vasculitis and lungs. Remember that there is a possible hemorrhage, and then possibly you should expect increased DLCO, although this has nothing to do with diffusion itself. The diffusion is going to be worse. Okay, and then you have a very special and serious disease, and that is called idiopathic pulmonary fibrosis. This is called idiopathic pulmonary fibrosis, or IPF, in the US. In Europe, there's a synonym, and we call it cryptogenic fibrosing alveolitis. And it's a mystery. We don't know the cause, but nowadays there are some new papers that are talking about gastroesophageal reflux disease, or there is some connection. Like in 90% of patients, if they have idiopathic pulmonary fibrosis, they also have in 90% gastroesophageal reflux disease. Okay, but we don't know the mechanism. That's definite. Okay, and what is interesting is that in this case, only lungs are affected. There's a fibrosis going on. You're 40, 50. This is the time when it starts suddenly. You're having a fibrotic lungs. Okay, and unfortunately, these cases, if they're lucky enough, they will end with lung transplantation or even heart and lung transplantation. That's the only way how to solve this problem, solve this disease, with transplantation. Because all of these diseases, again, if you're having interstitial lung disease, of course at the end you're going to end up with right heart failure, so with cor pulmonale. So many patients, they have already signs of failing right heart, like increased JVD, etc. Okay, so increased pressure in the jugular veins, etc. Okay, so jugular venous pressure is going to be increased because they're not able to pump the blood forward into the lungs because the pressure in the pulmonary artery is increased. They have a pulmonary hypertension. Okay, so, and if we get more specific, I'm going to pick some of them only. Okay, so remember, first of all, maybe we should talk about the idiopathic pulmonary fibrosis, which equals to, as I said, the cryptogenic fibrosing alveolitis. That's in Europe. Okay, Europe, big E. Okay, Europe. So this is a really awful disease, and as I said, it starts like suddenly, typically 50, 60 years old patients, or 40 till 60, depends, even like late 40s. And unfortunately, there's no way back. It's a way for lung transplantation or heart and lung transplantation, and we don't know the etiology. That's why cryptogenic etiology is, we don't know. We don't know what is the cause. Okay, so, but interestingly, only lungs. Remember, only lungs. Okay, then we have, for example, sarcoidosis. And with sarcoidosis, that's a special disease. We don't know again the mechanism. We don't know the etiology of. But remember, lung signs are the most common ones in sarcoidosis, and it has many other signs like joint. They have joint problems. They have skin lesions. They can have also kidney problems, etc., etc. But many of them just, you do a X-ray of the chest, and what you see, and what is so crucial, a crucial sign is a bilateral hilar adenopathy. And if you see this bilateral hilar adenopathy on an X-ray, this is a hallmark. And basically, the patient doesn't have to have any signs or symptoms. But if you see this on an X-ray, it's very likely sarcoidosis. But this is crucial because if the patient has some symptoms or signs like cough or uveitis or CNS problems or kidney problems, then of course you have to treat. But if it's a, let's say, silent sarcoidosis where you diagnose that accidentally on a X-ray, then you can pretty much wait with the patient. You don't have to treat, you just monitor the patient. That's very crucial, okay? And remember, this is a non-caseating in contrast to tuberculosis, for example. First of all, it would be a caseating granulomas, what you would see in case of tuberculosis, and it would be rather one-sided, so one hilar space would be affected, right or left. In contrast to this, in sarcoidosis, the bilateral hilar adenopathy is so crucial. It's typical. That's what you see on an X-ray. And not only this, but also that the granulomas will be non-caseating. Okay, that's crucial. Non-caseating granulomas in sarcoidosis. Again, in contrast to tuberculosis, over here the granulomas will be caseating. The important thing that I forgot to mention over here in the general signs, of course, or for the evaluation, crucial thing is biopsy, okay? So in all of these diseases, of course, definitely if you want to know the cause of the interstitial lung diseases, the ultimate thing to do is biopsy, and especially, for example, in the idiopathic pulmonary fibrosis, I jump back to idiopathic pulmonary fibrosis, okay, watch out. So over here, this is typical. We have to exclude everything, and it's sort of a diagnosis by exclusion. So you do biopsy over there, and you won't find anything else, so it's very likely idiopathic. Well, if we come back to sarcoidosis again, so remember, non-caseating granulomas, okay? And they can have many other things like skin lesions, eye lesions. They can have kidney problems. Typically, who you see over here, those are African Americans mostly, or if we talk about Europeans, rather from Scandinavia and the northern countries in Europe. Okay, so sarcoidosis, and what is crucial, and we talked about it, or very interesting, and we talked about it in the calcium seminars. Remember, these people, they have activated macrophages and other, let's say, immune cells in the lungs. And these macrophages have one feature, and that is they are able to transform the calcidiol into the most powerful form of vitamin D, and that's calcitriol. So typically these people, they have hypercalcemia. And this is like exaggerated, especially in summer, where if they go, on sun, the calcemia really increases. So remember, bilatelar hilar adenopathy, non-caseating granulomas, we don't know the cause, and remember hypercalcemia. Another field of diseases, those are the, let's say, autoimmune diseases, and you can put here SLE, systemic lupus typically, or Wegener, granulomatosis, which actually nowadays we call GPA. Okay, so remember that, and basically, we can talk about also amyloidosis, of course, and many other diseases that also impact lungs. So these are the let's say, systemic diseases, and then don't forget the pneumoconiosis. And I already mentioned, so remember asbestosis. And this is important because people that inhaled 20, 30 years ago asbestos fibers, now they can have problems. Now they can have asbestosis, okay? And, asbestos was used for hundreds of years as a insulator, heat insulator, because it's not flammable. So it was a great fire-resistant material. So they used it anywhere. Basically, before, let's say 1950s, you could find it anywhere in the houses, and the ban of asbestos started like 1990s and more. So that's why in all houses you can really, houses built before 1950 definitely, or even 60, they have asbestos insulators, they have asbestos roofs. Okay, anywhere if there's an insulation around heating or whatever, it could be made out of asbestos. And even, it's asbestos was found great for friction, so for example, brake pads in cars, it was made out of, or asbestos was a part of the material. So again, the people in car services that were changing the asbestos brake pads, they could be in danger. Okay, so, and every time we were braking, basically we were releasing asbestos around the car. Okay, so asbestos was used so much, so you can still find it everywhere. And the ban was like 1990s, so still there are many people that were exposed before 1990s to asbestos. So of course the amount of people is decreasing, but still you can meet many people that got in contact with asbestos. Okay, and they could inhale just a bit, but after 20 years there's inflammation, there's fibrosis going on, and unfortunately, remember, in combination with smoking, they have like 100 times increased risk of bronchogenic carcinoma. Okay, so that's the most common cancer in association with asbestosis and smoking. So immediately when you find out they have asbestosis, tell them to stop smoking. And remember, less common but very typical, and that's what you see typically with asbestos, but it's less common, is mesothelioma. So tumor which comes from the pleural spaces, okay, from the pleurus. Very devastating and awful tumor. And then, interestingly, still remember, if you check the lungs with asbestosis, mostly the lower parts of the lungs will be impacted. In contrast to this, in silicosis, those people work with glass, etc. Mostly the upper parts of lungs are impacted. Okay, so silicosis, again, very common, and the interstitial inflammation is really severe. So silicosis, remember, upper lungs, That's what you see. Over here, there's a big problem because in the upper parts of the lungs, if you can remember, also the tuberculosis stays, TBC, and typically this can mask maybe a, let's say, infection by tuberculosis because they think it, on the x-ray it looks like it's silicosis. So that's why you should really make tests for tuberculosis all the time. So test for TBC. Okay, tuberculosis. Okay, that's very important. So this can be masked. Okay, and then the co-workers, pneumoconiosis. Over here, it's not so severe. Interestingly enough, they're especially people with some kind of autoimmune diseases, or at least in blood, they have many antibodies against all kinds of things. So remember, typically, this is serious in patients with a different autoimmune immunoglobulins. Okay, that's interesting. Okay, so remember, pneumoconiosis, asbestosis, silicosis, cold worker, pneumoconiosis. And then remember the systemic autoimmune diseases like SLE or Wegener's granulomatosis. Remember amyloidosis. And remember unknown cause or etiology, that sarcoidosis as a systemic disease, and then specific disease of lungs, and that only impacts the lungs, and that's the idiopathic pulmonary fibrosis. These are the most important diseases that you should really know for the interstitial lung diseases. Okay, so these were the diseases and signs, and let's get to pulmonary function test, and let's get through some parameters where we're going to talk about more in detail about the obstructive and restrictive diseases. Okay, so thanks for watching, and don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.